Welcome to the Health Informatics Seminars. I'm David Potenziani, and I'll be hosting today. A quick announcement. Please remember that today's seminar is being recorded. Do mute your microphone while we're viewing the presentation and hearing our speaker. However, when we come to the Q&A, please feel free to unmute yourself and pose questions or make comments for the presenter to discuss. Alternatively, if you want to, you may post in the chat where I'm happy to relay your question or comment. So today we are going to hear about electrocardiographic AI from Professor Oguz Akbilgic of Wake Forest University. He is a health informatics researcher specializing in artificial intelligence and statistical modeling for healthcare. He develops AI-driven risk prediction and remote monitoring tools, integrating models with wearables, and has received multiple federal grants. His innovations include an FDA breakthrough designation for non-invasive cardiac monitoring via wearables. Please begin.
Thank you so much for the invitation and for this opportunity. Today my talk is about electrocardiographic artificial intelligence. We also call it ECG-AI. So we are going to talk about how we move it from lab to clinical implementation. Just to disclose this, I know like everyone in the room knows AI and does AI maybe more than I do, many of you. I'm not going to go too deep into specific like methodologic details of the model, but I want to more focus on about the steps of taking it from model development on the computer to clinical implementation. And these are my disclosures. So like in the most like a layman term, like we can define AI as like when we design computers or machines to think or act like human, so that they can carry out the tasks human can do, or maybe exceed it. Like so that we want a computer, if it sees a cat, it should say it's a cat, like an average human cat. Or when it scans an MRI image, it should be able to write a report like an expert does. Or it can scan thousands of textbooks and can summarize their joint theme within a couple of sentences in a paragraph. In the first example, we are just like mimicking what human can do already. And then we are in the next one, actually we are asking AI to do not necessarily an average radiologist, but a very experienced, seasoned radiologist can do, so that this can help with the knowledge transfer. But then now we are actually with AI, help of AI, we are able to exceed what human can do, so that like scanning thousands of textbooks in fraction of like a seconds or minutes and summarizing it is way above what we can normally do. And when we want to do all this within the artificial intelligence, we use machine learning as a core within AI systems to help us process the input and turn it into a results that can be translated as a meaningful information. Specifically, when we talk about the AI and in medicine, like in all industries, AI is also a hype buzzword in medicine as well. When we look at the trajectories since 2000, very brief, like a simple PubMed search using artificial intelligence, these are the number of publications. We can see the trend, increasing trend from 2000 to 2014. We see like a 44 times more publications in 2024 compared to 2000. But of course, there are some advancements in the biomedical engineering technologies. We had the AI element decades ago, before 2000, deep learning, they exist. But more like advancements in the GPU technologies, they are like a dissemination even in the consumer level computers allowed like execution of these AI models. And then the ImageNet came, so that now even if we don't have a very specific domain-specific large data, we can have foundational models to have them retrain, tailor them, fine-tune them for a specific problem. But then, of course, the ChatGPT a couple years back, it caused like, I guess, the biggest like a revelation that, okay, now we are ready to integrate AI in medicine as well. And these are the reflected in the trajectories. But see, if we want to be specific, look at the specific domain, like for example, heart failure. When we put heart failure as a search term, so there are like 5 times more publications from 2000 to 2024, but it is actually not a very fair comparison because there are more journals, more authors. If you want to put in a context, if you put both heart failure and artificial intelligence, there are like more than 100 times more publications we can find in the literature. These are all showing the great interest in applying artificial intelligence to solve clinical problems. But when we look at those, like, I mean, if I may go back, like we are talking about like tens of thousands of publications, but how many of them are really making it into clinical implementation? Probably less than 1% of them. So, yeah, but why? Why we have that many AI models developed, but they are not really making it into a clinical application? Well, it can be for like a multiple reasons. Well, it may not be answering an actual clinical need or clinical gap. So there is no need to use that AI model, maybe. And also like if a AI model, if we really want to use it in the clinical problems, it should be feasible to implement. So for example, an AI model that can early detect heart failure from cardiac MRI, probably we can develop a really accurate, close to perfect models, but how useful it is, because if a cardiologist have the MRI, probably they already can do it. So AI doesn't really contribute in this context, despite it may be very generalizable, very accurate. Another problem is, while we don't have capacity, enough ECG, enough MRI machines, MRI techs, radiologists, or we cannot cover that cost of screening people for heart failure screening with MRI because it is very expensive. And of course, the lack of generalizable, this is more our terminology in the statistical modeling or AI. So, so we want AI to work on the patient population that we are interested in. And the generalizability may be lacking due to multiple reasons. It may be due to careless validation strategy that causes data leakage, or the model may be trained on a cohort that is different than the cohort of intended use, so that the findings or AI model, the learned patterns are specific to that cohort, but doesn't generalize to the other cohorts that we are interested in. But of course, poor study design also contributes to this thousands of AI models never making it into clinical implementation. This actually worth a little more further discussion, so I have a separate slide for this. So here I would like to give an example. Like for example, like coronary calcium is one of the strong indicator of like a cardiovascular aging and the cardiovascular disease. If it is measured through computed tomography. So a total Agatston score is calculated from the CT. If it is 0, it's a good thing. It is no risk zone. If it is 1 to 100, mild risk, to 100 to 400, moderate risk. But if it is more than 400, it indicates a severe risk zone. So here now let's think about the AI model that can classify electrocardiograms into no risk or severe risks. Why would we would want to do this? Because not necessarily everyone is getting a CT, but much more people can get electrocardiogram. We have more than 300 million electrocardiograms recorded in the United States alone. Repurposing these for coronary calcium would be a great, it's actually from the clinical need. It is really addressing a major clinical need. And then, and these are like from actual paper actually. So this is a real published study. Inclusion criteria is anyone who had CT and the total Auguston score is calculated. And exclusion criteria, since they had interest in classifying no risk versus severe risk, excluded all the ones with the total Auguston score of between 1 to 400. The gray area is excluded. And actually ECG, and then they develop an AI model that takes the ECG as input and tells whether your Auguston scores, your zero or like a no risk or severe risk. Well, I mean, like in terms of clinical need, in terms of the like AI model development, everything looks fine actually. But when you look at it, this is not feasible. This cannot be implemented in the real world because to be your inclusion criteria requires to know your Auguston score. Because if basically if we develop an AI model, we cannot assume that this AI model will work on people it never seen their data from. This AI model never seen a ECG of a person with Auguston score of in the gray area. So that when let's say we have this model now, we want to implement a new patient, we have their ECGs, but we don't have their CT, we cannot implement it because we don't know their total Auguston score. It's like almost like a vicious cycle. So it's like a poor study design kind of led this model to be not usable in real world. And if I may give another like a similar example, so let's say we are trying to develop an AI model that can detect low ejection fraction. That is a strong indicator of heart failure. So if left ventricle ejection fraction is lower than 40, that is calculated from echocardiogram, it is called low EF. It may be called low EF. Some may classify as 35, but let's say it is 40. If it is between 40 to 49, it may be mildly reduced or mid-range EF. If it is more than 50, it can be either no heart failure or it can be HFpEF with just preserved ejection fraction. Anyway, so let's say the AI model's goal is to take the ECG as input so that we don't need echocardiogram. Just take the ECG as input and to tell whether the patient has low ejection fraction or not. And the goal is to do population level screening so that without needing for echocardiogram, we can just screen people with ECG. And then if they have detected as low EF, we can refer them to echocardiogram for confirmation. So inclusion criteria here is, of course, anyone who had at least one ECG and echo pairs, so that we can use ECGs as input, echo as outcome. And then this study is done in a hospital setting. Exclusion criteria is who have like a mildly reduced EF or HFpEF. So the cases are people with low EF, controls are people with no heart failure at all. So again, this study is not implementable. This is also, again, from the literature. This is also not implemented in the real world for multiple reasons, actually. If I may just grab the example from the first one. First of all, in this example, this data never learned from patients with mildly reduced or HFpEF. These patients had to be included in this study as a control. So if you want this model to just isolate low EF people from everyone else, they should be included in the controls. So basically, we don't know whether the AI model learned the patterns of low EF or learned the patterns of not being normal. So that, for example, if you give this, if you feed this model with ECG of someone with HFpEF, we don't know what it's gonna do. So this is the first reason it cannot be used in real world. The second reason is, look at the inclusion criteria. Anyone who had at least one ECG, one echo. Anyone may have ECG if they express some like a palpitation, sometimes chest pain. So getting the ECG is much more like a less biasing. But having an echocardiogram, you need to have strong symptoms or worsening symptoms of cardiac complications so that you would get echo. So basically, this cohort itself is very biased. Those are the people who clinically had clinical indication for need for echocardiogram. So now it is a very, very big stretch to say that now we can screen everyone with ECG. So those people will include people who never had any indication for echocardiogram need, and then use them to decide whether they have low EF or not. I'm not saying that this may not be extended to use that purpose, but out of the box, we cannot claim that this model will work on people who doesn't need echocardiogram for clinical reasons. So in summary, a lot of AI models are not translated in the clinical implementation because they are either inclusion criteria, exclusion criteria, or one of the input relies on availability of the output, which is kind of like a contradictory. So that's why actually there we can define two different concepts. So AI in medicine and AI for medicine. So they are really overlapping concepts, but there are like some differences as well. In AI in medicine, we can say we developed AI model, not necessarily developed to solve a medical problem, but now we use it in the medical domain. AI for medicine, now we have an actual clinical problem, and then we try to solve it using existing models. If existing models are not enough, we develop novel models, but our main point is to solve a clinical problem. It may be like someone is doing PhD thesis on a novel convolutional neural network, just wants to apply it. They may find medical data. This is just fine, but I'm saying it may not necessarily need to AI that is implementable. They may just be developing a CNN model. They just want to test it on a medical data. This will be just fine. But doctor may have some problem saying that my patients keep coming back to hospital soon after discharge. And now we may try to find some AI models or develop novel AI models to solve that exact problem so that we can find patterns of the readmission that can guide clinical decision making. So if we talk about AI for medicine, we can lay a couple of like main rules or like principles. First of all, it should be actionable. Does it solve a clinical problem? Is it accurate enough so that it will be like a clinically actionable? Also really, really important, does it really change the outcome? Like predicting something, a clinical event is one thing, but can we change anything in the course of like a patient outcomes or the healthcare resource utilization? If we cannot change anything, even if it is accurate enough and addressing a clinical problem, it may not be really like actionable. Or even more importantly, are we living in a institute, healthcare program that has infrastructure to implement to embed this AI algorithm, not only to implement it, but also maintain it. So these are all like a different like aspects that are affecting actionability. The other one is generalizability. Of course, I don't want to say that any AI model should work everywhere in the world for all the patient populations, but at least it should be generalized to the patient population that we are interested in. So, but there are like many statistical AI ways to ensure that, like we say, cross-validation, external validation, blinded validation, and also explainability. Can we explain this AI model to clinicians and potentially to patients to what AI finds? Because we are going to make a decision about their patient's care using this AI. We should be able to explain. By the way, I am not saying the first two are mandatory, really like a must-have. Explainability. There may be reasons that AI is really solving a very, very important clinical problem, but we are not able to explain because of its complex nature. There may be situations it is fine, but like the first two are really we need to have. And also trustworthiness. We can say, do clinicians feel comfortable to use this AI to make decision about their patients? And all this like other three actionability, generalizability may help boil down to like a trustworthiness actually. And actually, this was reflected on the like America's AI action plan as well. I guess the trustworthiness, that is I guess a component of all of them. I put the exact like a paragraph here because I feel like it is a very important paragraph. So they studied. So this was published in July this year. They try to understand what are the bottlenecks in harnessing AI in the entire industry, but also they focused on the healthcare as well. I mean, they found that it is not lack of methodology, it is not lack of resources, etc. It is really the slow adaptation, especially in large healthcare organizations. And it is really boiling down to the trust into AI models. And then there are some like next steps that they laid out. But what I can deliver is that this AI, implementing AI in the clinical care is not going to come out from a postdoc or a faculty who really wants AI. It has to come from, demand has to come from, or at least appreciation has to be present at the highest level possible at the decision makers. Only then it is actually possible to move things forward. So now, like after this point, I will try to be more very specific how I wish, I mean, I have been doing this work for some time. I wish I had like 20 different AI models implemented. I only have one, so I will give that as an example to see what steps it went through. So that is going to be a clinical problem, proposed AI solution, AI model development, and implementation stages. So we focused on the like a burden of the heart failure. So heart failure is a global burden, not only in the United States, but in the entire world. But it is not like a trigger event. It's not like we wake up one day, now we have heart failure while we didn't have it yesterday. It is actually a process. There's a time we are free from heart failure. And then it develops over time, like one day in our life that we start having symptoms of heart failure. It may, risk factors of heart failure. It may be hypertension, it may be obesity, it may be diabetes, left ventricular hypertrophy. There are like a clinically defined or accepted risk factors. Actually, if you have one of the risk factors, you may be considered as stage A heart failure. But of course, you are like most likely you are asymptomatic at this stage in terms of the heart failure. And then actually disease start progressing. Now we are in the stage B. There is some like a systematic like a disease started developing, but still we may be on asymptomatic or mildly symptomatic stage, or at least the symptoms that may not necessarily be contribute. I mean, decided as it is a heart failure. And then we move to stage C or D, advanced heart failure, which is associated with very frequent hospitalization, heavy medication, poor quality of life, transplant, 50%, 5-year survival rate of 50%. So this, and unfortunately, heart failure is typically diagnosed at stage C or D. This is a real problem for individuals, for reduced quality of life and low life expectancy, and also for healthcare system. Heart failure is the #1 contributor to the healthcare utilization in the United States. So what we need to do is to detect heart failure at the stage B. I mean, we can do it at stage D, but it will be more risk prediction. But the stage B, because structural heart disease has already started. Well, good news, we have all the tools we need for gold standard diagnosis of heart failure. Bad news, they are expensive, they are not accessible, and they are not a part of population level heart failure screening, which we do not have. We have population level screening for breast cancer, for colon cancer, if you meet certain like a criteria based on age, based on gender, of course. But there is no such a thing like a heart failure screening, because those modalities, despite like an echocardiogram, MRI, CT, they may be gold standard diagnostic tools, but they are very expensive. They are not accessible. They are not a part of a population level screening. That's why if you want to detect heart failure in stage B, we need low cost, easy to access, and scalable tools that enable timely recognition of the heart failure. Well, so that's why we use ECG data a lot. Not that we are data agnostic, we are data scientists. We don't like ECG more than echocardiogram. But well, ECG is low cost, accessible, and also remotely adaptable. On the left-hand side, you see one of the first, it's the first ECG machine, 200 pounds. But now ECG in the clinics, very small, like mobile devices, as well as ECGs on our wrist from our watch or a chest strap while running. We can record ECGs. As an AI data scientist, what excites me about ECG most is that it is very AI friendly. What I'm saying is you may have like a medical imaging MRI machine, maybe 15 years old. You may have developed one of the best model that takes those images as an input to classify certain tumors. But this imaging technologies advances a lot. They get much better and much better. That's why AI models developed on like a very old images are not necessarily gonna work on the images from the new generation devices. But in the AI, on the left-hand side, and time to voltage data from 1920, time to voltage data from 2020, fundamentally, they are the same. We develop AI models using data from 1980s, 90s. We tested on data from last year. It works. So we talk about the ECG-AI. Just very briefly, I want to give you background of what we mean when we say ECG-AI. We already know a lot about ECG. We know all this like QRS, PT, those like intervals, complexes. And we know the normal ranges of it. Like for example, in a normal sinus rhythm, and the time between two R peak should be 0.6 to 1.2 seconds, for example. If it is more than that, it may be bradycardia. If it is less than that, it may be tachycardia. We already know what is normal and what abnormality they indicate if we go outside those ranges. So this is the conventional list of ECG. But if we would do, for example, more feature engineering, like for example, we can use those non-ECG features, like for example, what's the T-wave amplitude, T-wave duration, and use them as an input in the machine learning. Well, then we may be doing ECG-AI. Or we can implement more signal processing, Fourier transformation, wavelet transformation on those signals, and then use them in like a shallow machine learning. Still, we will be doing ECG, but more commonly and more recently, what we have been either you use the entire time to voltage data or the image of the ECG as an input to deep learning and let it find its own like features through the deep learning convolutional or RNN LSTM mechanisms. Still, we are doing deep learning. So basically, I can say like ECG-AI is unconventional analysis of conventional ECG. So if I may go back to problem here, the problem we identified, the clinical problem we identified, urgent global need for low-cost, accessible, scalable system facilitating timely recognition of heart failure. And then our proposed solution is not only AI model, we need to tie it to the like a healthcare. It's a new care model utilizing ECG via AI for improved diagnosis of heart failure. So now we are not only trying to develop a AI model, but also trying to link it to the like a clinical workflow. So here we took like two different approaches because we generate a lot of ECGs in clinical setup, like more than 300 million ECG a year in hospitals, in clinics. So, but also due to the consumer level device like Apple Watch or Cardia or like a Fitbit, we also generate ECGs at home. So like we don't wanna leave any gap. So we wanna utilize both of them. So if I may start from the again, the first approach will be internal use. So basically, how do we bring AI into actual patient care? Again, it can be through two approaches. One, internally, like for example, we at Wake Forest, we develop an AI model, we validate it, and then we embed it in our like a clinical workflow as a quality improvement project. Like for example, there's a ACCVD risk calculator from AHA. It may be embedded in the EHR. So clinicians may be looking at it and then deciding on whether they want to do more close monitoring, they want to order some labs, etc. This may be one way. And then in this specific test is like a low ejection fraction from electrocardiogram. Well, second approach, external, if we want to use it anywhere in the world, and then we need to go to regulatory space. We need to get FDA clearance. So in this domain, we want to do this through the BNP estimation from ECG. BNP is a lab test. That is like a blood test that shows the severity of the heart failure or like the existence of heart failure. Let's start, if I may start with the approach one, which is the like a homebrew model development and the clinical implementation. So heart failure usually can be in both like a left heart or through the right heart. So we usually call left ventricular dysfunction if your low ejection fraction is lower than 40. It is, we call it REF, but it usually lead to HFrEF, heart failure with reduced ejection fraction, or your ejection fraction may be between 40 to 50%. I mean, many of you know, but just literally what percent of the blood come to left ventricle is pumped to the body. So if it is less than 50%, it indicates left ventricular dysfunction. Anyway, but still, more than 50% just normal, it is preserved, more than 50% of the blood is pumped, everything may look normal, but actually you may still have heart failure, then it is called heart failure, preserved ejection fraction, or of course your EF is more than 50, and if you don't have heart failure, then you are controlled. So as you can see, there is no gap. So anybody can be assigned to one of those categories. So the method we choose was how to develop a convolutional neural network that takes electrocardiogram as an input, process it through the convolutional layers, and then outputs the probabilities for this ECG would be coming from a person with low EF, REF, mid-range EF, heart failure, preserved ejection fraction, or none of those conditions. So we are at Wake Forest School of Medicine, like many of you know, we merged with like Atrium Health and then the Advocate Health. We are lucky enough that we could build a very large ECG repository of like a 16 million ECGs linked to millions of patients with their like a clinical history. We utilize our dataset. When we started this project, Atrium and Advocate data was not in, so this is only based on the Wake Forest data, but we used over 1 million electrocardiogram data from 165,000 patients. And we built an AI model that takes the input as electrocardiogram and then gives the probabilities of having reduced EF, low EF, the same thing I highlighted in red, or mid-range EF or HFpEF. So we split our data for like training, validation. While using this training and validation, we identified our final model, and then we tested this model on the another 20% holdout data. These are the results you are seeing in the Wake Forest and holdout data. We had the AUC of 0.89 in detecting low ejection fraction. And then next step, we gathered data about 74,000 ECGs from 42,500 patients from Memphis, Tennessee, from University of Tennessee. And then without any fine tuning, we external validated our model, data from University of Tennessee. And our model, I'm highlighting the reduced EF because this is the one implementing in the clinic. So low EF detection accuracy, we got 0.9 there. That's great. And then we had the chance to work with the Ministry of Health in Turkey. They have a central healthcare system. All data flows from all hospitals to one location. So we worked with them. We had a chance to do a blinded external validation. They literally gave us ECG data. No outcome, we don't know. We run our model. We sent them the probabilities. And then they just sent us the results. We got 0.89 AUC. Now we are talking about AI model developed only using data from Americans, but now it's validated in a completely different country, different continent. Now it still works with almost exact same accuracy. But again, our ultimate goal is to see whether we can do screening of heart to low ejection fraction, because still there is a little bit bias because it's EHR-based data. Everybody had the indication of ECG. But that's why now we moved to rural study. Rural health study is a cohort study carried out at like 4 states, Mississippi, Kentucky, Alabama, Missouri, to understand the cardiovascular and pulmonary risk factors in rural communities in America. There's a mobile unit, goes to enrolled patients, and then gets their ECG just because they are in the state, gets their ECG, CT, echocardiogram. So now we had a chance to test our model on ECGs that were recorded without any clinical indication. And we got the AUC of 0.91. So like all the studies we had to go through, it took maybe 2.5 years. But at the end, now we have an AI model that is generalizable, accurate, and clinically actionable enough. If you look at the positive predictive value, it's almost 20%. Like basically, every 1 out of the 5 people we flag with low EF will really have low EF. But there is, and the negative predictive value close to perfect. Like literally, if we rule out patients from low EF, they don't have low EF. But there is something more interesting actually. When we look at the false positives, actually, 1/4 of the false positives had mildly reduced EF. They were not literally completely healthy patients. So basically, the clinical utility is much more than the positive predictive value, the 20% you are seeing here. Actually, almost half of these people had some form of left ventricular dysfunction, still need attention. So that's why since our accuracies in the low EF was much accurate, so we move forward with the low EF detection for clinical implementation. But again, does it improve health outcomes? So we had to show that as well. Well, first of all, there's a strong literature showing that earlier diagnosis leads to better outcomes. But of course, we cannot rely only on the literature. There is actually a clinical trial done by another group. We're using a similar, like a low EF model, and they show that actually using ECG-AI to detect low EF, if we do that, first we diagnose more new onset left ventricular dysfunction, but also it optimizes the echocardiogram use. It's not necessarily increase the echocardiogram use because of the high negative predictive, it actually optimizes it. But we still had to show data from our enterprise. This part is very interesting. So now we have a model that can detect like a heart failure or a low EF, right? Or when we built the model, we used, let's say someone had ECG and echocardiogram at the same time. Echo was 35. Of course, this is our case. We use ECG from that time as an input to estimate this low EF. And this is when they had the first time low EF for the heart failure diagnosis. And then we went back in time. In our system from those patients, actually, we had their older ECGs, like years before their heart failure diagnosis. And then we run our model on those ECGs, the older ECGs. And by the way, this is only happening in the holdout. So there is no model never saw the data from those specific patients. Very interestingly, up to 3 years before the actual clinical diagnosis, those ECGs, our model still classify them as heart failure or low EF. So this actually shows another utility. Actually, there is at least like a 3 years, like a missed opportunity that we could early diagnose those patients. So now this is our clinical implementation. So now we are tying it to actual new care model. And now this is not the IRB research anymore. This is from now on, it is a quality improvement project we are doing. So, but we are now talking about advocate health, like we are caring for 6 million, more than 6 million patients. It needs to be like a phased step-by-step approach. First, we selected a pilot clinic, which selected one of our family medicine clinic. Now we want to implement it and understand the ins and outs of the implementation. and also build the infrastructure, which is the most time-consuming piece as of now. So basically now, anyone comes to our clinic, this is the care model we are talking about now. Anyone comes to our clinic, if they meet the inclusion criteria, which is any adult with hypertension. We said hypertension because it is the most important risk factor for heart failure. With hypertension and or a heart failure symptom, such as dyspnea. Anyone comes to annual exam, for example, with one of those conditions, they are included, and all of them are getting 12-lead electrocardiogram. Once this 12-lead electrocardiogram is recorded, we are a Muse shop here. We are using GE as a vendor for ECG. Our ECGs are going to the Muse software, where our clinicians are looking at and interpreting ECGs. So from Muse, now this piece is not existing. So from Muse, we need not only the PDF, but actual waveform ECG. We are building this AI server. Actually, we have done this. Automatically pulls all these ECGs to this AI server, which hosts our AI model, and then it runs. If it detects low EF, classify as a low EF, and send automated referrals for echocardiogram and BMP. So why we stop here? Because we already know there are already protocols, clinical guidelines to do if someone's BMP is more than 100, there are already clinical protocols. If someone's echo shows low EF, they're all clinical. So basically, we are trying to develop this care model to connect underdiagnosed heart failure to existing clinical pathway from the lowest level possible. And actually, we did like a lot of work on this, which increased, of course, like first of all, demand came from our National Heart and Vascular Service line. Without that, it wouldn't happen. Our leaders of the cardiovascular service line wanted this to be implemented. I don't get credit over here because without their push, without their ask, it wouldn't happen. Clinician involvement. So I'm a data scientist, but I work with like very closely with clinicians because we need to have a clinical protocol. If this is going to be a part of a clinical workflow, it has to consider all the demands, limitations of the clinical workflow. And also now we are like working with heart failure doctors to develop protocol, but it is implemented in the family medicine. If we also go to the family medicine clinics, get their approval, get their comments, edits, adjusted. And now it comes to the IT needs. So it needs to get cybersecurity approvals, IT governance, because IT is the one helping like designing this AI server, building it, maintaining it, and sending HL7 messages to Epic. And also like AI assessment. So we are lucky that we have enterprise committee, fair AI committee that assess every single AI model that is used in the advocate health. So it is a lot of work, but it is definitely doable. So basically after this, hopefully by mid-December, we are almost ready with most of the components, couple of like a testing left to be done. And we are kicking this implementation off in December. I'm also checking the time. I will also want to have some time for Q&A. I think I can go through this part quickly. So another approach, what about patient who doesn't come to annual exams, who doesn't get 12-lead ECGs, but who already has Apple Watch? Well, so there's this BMP test, like again, a biomarker. You do like a blood test. If it is less than 100, you are good. If it is more than 100, depending on how high it is, it may be a strong indicator of heart failure. But it is not only it doesn't only have utility in heart failure detection, but also have utility heart failure prognosis. If it is, it also shows worsening heart failure. The higher it is, more the filling pressure is. It means that your heart failure may be getting worsened. So, and like I think many of you have seen this, like electrocardiogram capable of the Apple Watch came out in 2017. But all it does is atrial fibrillation detection. Now we say, well, what if we could do more? What if we could also estimate the BNP from the ECG in the Apple Watch? So for that, this time our input has to be single lead ECG, because those Apple Watches record only single lead ECG. Outcome is the BNP pairs. So we get the hundreds of thousands ECG and BNP pairs recorded within 2 hours time interval. And then develop the AI model, takes the ECG as input and gives the estimated BNP. We call it eBNP, or estimated BNP, and then we compare it to lab BNP. Actually, there's a strong correlation between them. Actually, it detects, when we use lab BNP versus eBNP to detect heart failure, actually it detects heart failure better. Of course, it may be contradictory how estimation of something can be better. Why here we are not using, we are looking at from the heart failure perspective, and apparently there's a condition called BNP deficiency, especially with the high obesity and the heart failure with preserved ejection fraction. Actually, body needs to produce BNP but unable to. Apparently our model also assigned them a high BNP like it should be. So that's why actually it detects heart failure better than lab BNP. And also it works in all subtypes of the heart failure, but also represent the clinical reality better. So what we have done is, this is a convenient study. We have a separate study, not that I want to distract you, but we are doing a study with the St. Jude Children's Hospital. There are childhood cancer survivors. They come to clinic as an adult every 3 to 5 years. And then for a comprehensive exam for the cardiovascular risks due to childhood cancer treatment. But when they come, we also put the Apple Watch on their wrist. We record their ECG. And they also do the lab test. Actually, when we run our model using the Apple Watch ECG as an input, actually we could detect elevated NT-proBNP, different type of natriuretic peptides, with really, really high accuracy. And then this is how we did it. Of course, we had to have a HIPAA-compliant mobile application. We had to develop that takes the ECGs and then estimate the BNP. And then this is this is how we are envisioning it. And I say envision, but this is actually up and running a mobile application that anyone can record ECG, that takes it and run the AI models either on the phone or in the cloud environment. And then we actually want to turn it into this is the care model we developed. Anyone has BNP, anyone has an Apple Watch or using our mobile app. Let's say they record an ECG. And first, whether they have heart failure or not. If they have heart failure and their BNP is estimated more than 100, we directly align them or push them to the existing clinical workflow. If they have heart failure and their BNP is estimated, shows more than 40% increase compared to their baseline, it means that they are at high risk for heart failure readmission, so that we can connect them with their providers, maybe a televisit to adjust their Lasix, or if their change is estimated less than 40%, they can be ruled out. And I'm not sure if I have time. This is actually how this a mobile application.
In this brief demonstration,
fast forward.
So
you literally record your ECG on your phone, like 30 seconds. This is actively me doing actually. I just recorded it. So once it is done, so you are going to your
Apple
phone.
Watch. We are turning on
this
our
is our application.
mobile application.
Well,
When I
click
click on
import
ECG, it is pulling the latest ECG I recorded in the waveform. And then when I click on analyze, it analyzes
that easy. Literally, you record your ECG, and then everything happens almost in a fraction of a second. Estimated your ECG, saying it is not less than, it is not more than 100. You are at low risk. So we actually, the thing is though, when we do this externally, go outside our healthcare institute. Now we need to define as a software as a medical device. We need to work with FDA. So actually, we also had the FDA submission. We recently got FDA breakthrough device designation, and then next steps we are working on to do the finalize the validation study, then hopefully just use it in even in the outside hospital setting. So basically, these are the steps we have done in this like approach to we built the AI model, like a HIPAA mobile application, FDA clearance. So we did the breakthrough device designation, and then we are trying to finalize the clinical validation. If I may try to summary, like AI for medicine is not only about developing the most accurate AI model. It is to develop AI model that solves a real clinical problem that is actionable, implementable, and also maintainable. And it requires real resources, real dedication, close collaboration with all stakeholders, and highest level support from the decision makers. And most importantly, it requires a lot of patience. That's the end of my talk. If I have time, happy to take questions.
Thank you. We invite anybody who would like to unmute themselves to ask a question or make a comment to do so, but if you want to, you can put your question or comment in the chat. I'm happy to relay it. But just to get us started, I do have one. I have a question that came up as I was thinking about your talk, and it has to do with the performance of this technology for people with rare heart conditions or those with multiple overlapping diseases. What is your thought about how to apply this approach or a modification of this approach for those kinds of situations?
Yeah, it's a very good point. Like I definitely see your point there. Like rare, like for example, ATTR cardiac amyloids, or it can be hypertrophic cardiomyopathy. There are already existing efforts by our lab, by others as well. Like literally ATTR amyloid detection is one of the model we want to develop. And you are like some of them like well, there is a cure if we know, but they are severely underdiagnosed, and then they never get the cure medication to keep. Yes, I mean, in short, yes, there is definitely need for it, and then there are active research on it by our lab and by others as well. But also, like this, like heart failure is very wide, but also it affects a lot of people. Like even our data shows that at least 3 years, we are at least 3 years late in diagnosis. There's a huge like a missed opportunity to bring them people in and maybe treat them even with some simple lifestyle changes rather than waiting for them to go really severe, waiting for transplant or but anyway, if I don't know if I could answer your question, but I'm happy to elaborate on it if you can.
No, that was very good. Deborah Swain, you have your hand up.
Yes, I hope I can say this clearly. I'm very interested in learning health systems and how we can speed up clinical implementations, Ogus, but I'm concerned about what you would say is the best AI research machine readable format that we should use. We don't want words only, you know, in an article. We want to be able to have computable shared information.
So my apologies. I think I have an idea, but I would ask, do you mind like asking your question again? I just want to make sure that I understood your question correctly.
Yeah, let me try. I work with people at the University of Michigan in mobilizing computable biomedical knowledge. So the Learning Health Systems group want to emphasize we have machine readable data and information in articles, not just human words. So what is your favorite format for getting this good AI computable data to other people?
Okay, so yeah, I think I have an idea. Well, again, I'm a data scientist, so I can work with any data, but the data I like the most is the lowest cost data that works in that can be expressed in even in text format or like a CSV format. So that's and also can be gathered not only in the hospital setting, because most of the things are happening to our patients outside hospital setting, also in the outside hospital setting. This can be data collected to do wearables or the simple like symptoms that are reported by the patients. I don't know if it is again like if it is the exact question I answered, but
well, we're in the same area working with you too on making sure you know that it's actionable and fair. So thank you, sir.
right, of course, thank you.
We have a question for one of our students.
Okay, I'm just at the end of the day, so I'm tired, but I want to ensure that did you apply this application for patients?
Yes, all our data was both retrospective and prospective, but the clinical implementation, as I showed you, we did all the steps. So we are kicking this study off like
How
a
many?
real clinical application implementation in this December in less than a month.
And how many patients you tested the app with?
Oh, I mean, we use hundreds of thousands of patients. For when I said testing, you mean the model development, retrospective and prospective testing, hundreds of thousands. But in real clinical implementation, then we are starting in December.
Yeah, I mean the clinical implementation. And I also want to ask about, did you consider normal people to test this app also as a control group?
Yeah, absolutely. Our control group actually in this specific example, if I may very briefly go back here. So this will show, sorry, for the animations, I guess I'm paying the price of. Okay, so here are cases for in this specific study, patients with low EF. For this one, everybody else is a control, whether they have other types of heart failure, other types of left ventricle dysfunction, or any types of arrhythmias, or free from any cardiovascular disease. They are all controls here.
Okay, thank you.
Of course.
So as we consider this, in a sense, being introduced into clinical practice, what do you think? You talked a little bit about how clinicians ought to be able to understand and trust this approach. What about the patients themselves? Is this just another mysterious thing that a clinician does and says, these are the results? Or how much do you think they should explain or need to explain to a patient?
Yes, this is a very, very good point. Like I said, there may be some models that saves life, very hard to explain. We still maybe use it. But in the mainstream AI analysis, we should be able to explain it. Here, first, we should be able to explain it to patients, to clinicians. What we are doing in that front is there are ways to do almost like a reverse engineer this model through, I mean, many of class activation maps. So basically, we put like a heat map on the electrocardiogram. So let's say someone ECG is input, output is yes, detected as high risk for low EF. We also put a heat map on the ECG, shows the areas of the ECG where AI used the most. So that actually then physician also has a chance to understand this is low EF probably because there's like elevation around the ST area or depressed like a P wave. So this is how we are trying to explain it to patients, to physicians. But then, of course, like you said, another component is to explain it to like a patients. But I really feel like with this like a new era of the AI, there may be some like a need for like a patient education training on the like a new use of the AI. Why this person is referred to echocardiogram despite there was no symptoms, for example. I think that component is also needed, that we may need to prepare some training programs for patients.
Okay.
If I may add one more thing here actually like FDA approval process, it makes it more challenging, but actually it also gives physicians more like a trust, because they don't want to probably make a decision about the patients based on an AI that they cannot explain. But at least if it is FDA approved software as medical device, they will be more confident, or maybe the liability would be a little, I guess, distributed.
One final question.
Of course.
Hi, thank you so much for this talk. I really loved your description of sort of AI in versus for medicine. I think that that is a perspective that is missing when a lot of data scientists approach this problem. So I really do appreciate that as a clinician. And then that brings me to sort of a question about the balance. Obviously, it's very important to think about feasibility, generalizability, sustainability. I forget how you phrased that, but I'm curious if there were questions or problems that got proposed from the clinical side where feasibility or accuracy weren't possible. What do you see as the options there? Do you know, what do you imagine the future looks like to answer those kinds of problems? Do we need more infrastructure or better AI models, or how do we solve the problems that clinicians see as important? These two are phenomenal, but what about the ones that don't quite fit that model?
So yeah, I feel like if I understood correctly, like when there's a clinical problem highlighted by a physician, before getting into developing an AI model for it, first I would do a feasibility study in terms of once we have this AI model, doesn't matter what method we use, doesn't matter if we develop a novel method or we use an existing model. How is it going to be integrated in the clinical workflow? For if it is in a, like if we are talking about a model that will help in the like an emergency department that requires additional 6 minutes of time of nurses, is it going to be implemented? Will they really use it? I feel like the accuracy would come later. Sometimes with the AI models, you don't know. Maybe you will get clinically actionable accuracy. Maybe you don't. But from the beginning, you would know whether it will be accepted in the clinicians. I think that even in that sense, like even from the study design, who is going to use this? As small interviews with those people who would use this, not only would highlight the clinical lead, but what if we have a solution? How can we integrate it? If it is not clinically doable, feasible, maybe it is not worth really doing it. And of course, many of times it comes down to additional resources.
Thank you. We are out of time. This was a very interesting presentation. I look forward to my students' discussion of this later on.
Thank you very much.
Okay, and we'll see everyone next week when we have a brand new format we're going to try out. It will be an experiment.